It's an honor to be here. I'd like to thank the organizers for putting together a wonderful series of lectures, and I'm pretty excited to be here to talk about infections as well. We just heard from Dr. Polan about the amazing strides that have been made in management of early onset sepsis. Well, I'm here to talk about a thornier issue, that of late onset infections in the NICU. I greatly enjoyed this morning's quality improvement session where we learned about how to use the evidence to drive quality improvement, and we also learned about setting priorities for improvement in the NICU. And clearly, whether it be in the Indian context or the Western context, reducing infections are an improvement priority. So with today's talk, I have two objectives. I hope to build upon the themes of the morning and provide you with some tools for quality improvement. And I hope to convince you that late onset sepsis, especially central line associated bloodstream infections, are preventable to a large extent. So let's start by looking at the scope of the problem. Here's data from the Neonatal Research Network that shows late onset sepsis rates in infants of varying gestational ages. And as we can see, the youngest, most immature infants are the most vulnerable and have the highest rates of late onset sepsis. But if you look at that table on the right closely, you can see that for each week of gestational age, there is wide variation between centers in rates of late onset sepsis. This suggests to us that there is a considerable practice variation in how we prevent infections from happening. Infections have serious consequences. We know that infected infants are at much higher risks of mortality. Dr. Schmidt showed to us yesterday from her TIP trial data that infections lead to higher odds of adverse neurodevelopmental outcomes. In addition, there's plenty of emerging evidence in recent years that have shown that higher antibiotic use itself is associated with adverse outcomes such as necrotizing enterocolitis, sepsis, and mortality. Now, in order to reduce antibiotic use, we have to reduce the incidence of infections to make practitioners comfortable to reduce their antibiotic use. So these efforts have to go hand in hand. So I hope I've convinced you that there's variation in our practice, and it is an imperative for us to try to reduce this variation in our practice. So what are the factors contributing to neonatal infection, and which of these factors are modifiable and which are not? If you look at some of the not modifiable factors, we know that immaturity, the degree of prematurity of the infant, and possibly genetic variation are things that we can't change. One might argue that some of the microbial factors are hard to address as well, virulence factors and maybe antibiotic resistance. But the easier aspects for us to work on, for us to focus on, are environmental factors, thinking about the hospital microflora, how to reduce the burden of bacteria in our environment, how to take better care of our devices like central lines and mechanical ventilation. The evidence is pretty clear that the longer you have a device in, the higher your risk of infection. The study here elegantly shows that with increasing duration of central lines of ventilation, with increasing delays with being fed, which is a surrogate for increased TPN use, your risk of infection goes up. So now I'm going to switch gears and talk about what we can do to reduce this risk of infection. I'm going to provide you with a general idea of the evidence base behind infection prevention and late onset sepsis and CLABSIs, and also provide you with some practical quality improvement tools that you can try to use in your NICU environment. So here are some general tenets for infection reduction using quality improvement methods. The first, as we heard this morning, is the development of an evidence-based bundle that fits your local context. But in order to do this, one needs multidisciplinary collaboration. One needs to set some clear aims and map out our processes. We need to set up some measurement tools by which we learn more about our local data. And then finally, we need to communicate, we need to educate, and we need to bring about a high reliability culture in our institution and think about how to change human behaviors to ensure that reliability. So I'm going to go into each of these themes in a little bit more detail. So let's talk about bundles. What is a bundle? The Institute for Healthcare Improvement says that bundles are a group of best practices, which individually improve care, but when you put them together, they result in substantially greater improvement. And when you combine evidence-based care practices with consistency in application, that will lead to improved outcomes, in this case, reduction in infections. So how do you go about creating your bundle? Well, one can't start talking about infection prevention without talking about hand hygiene. Here is an observational before-after study that looked at implementation of hand hygiene practices in a unit. And what they showed very nicely was an association between changes in hand hygiene compliance on the left and changes in sepsis rate on the right. During phase 1, which was their intervention study of their hand hygiene study, they saw a nice rise in their hand hygiene compliance with a corresponding decrease in sepsis rates. But as their intervention sort of faded off and hand hygiene rates dropped, their sepsis rates rose again. And then when they went into sustained mode and tried to bring back better hand hygiene compliance rates, they saw their sepsis rates drop again. Very nice proof of concept of the fact that hand hygiene works to reduce infections. So moving beyond hand hygiene, what are some common sense improvement strategies for each NICU? So we all talk about hand hygiene, but how do we actually make this happen in our NICUs? The first step is obviously education about why this is important, why it matters, and why it matters every time you touch a baby, to make sure that you have clean hands. The second is to get hard data from your unit. Audit your practices to get an understanding of what's really happening out there. It could even be one baby. You could just observe hand hygiene practices around just one baby in a unit and see how many times there are misses in hand hygiene to get a sense of how much improvement can be seen. And crucially for hand hygiene practices, one needs to empower all staff to be able to speak up. Be it a bedside nurse or a patient's parents, everyone should feel like they can speak up and make sure that their patient or their child is touched only after hand hygiene has been performed. So beyond hand hygiene, other elements of central line infection prevention include the setting up of central line insertion checklists and central line maintenance bundles, as well as thinking daily about whether a line can be removed or not, doing all we can to get our lines out as early as possible. Let's look at a little bit of the evidence for these CLABSI bundle elements related to insertion and maintenance. I apologize for the small size of this table, but I wanted to put this up because I wanted to give a shout out to EBNEO 2011. This was a review that came up with evidence grading for CLABSI prevention in neonates based on discussions that were held in EBNEO 2011. And you can see that they've graded, most of the grades for the elements are either 1A or 1B. And category 1A stands for evidence that's strongly recommended and strongly supported by well-designed experimental, clinical, or epidemiologic studies. So things in the insertions checklist that are 1A are, of course, hand hygiene, but also using maximal sterile precautions when putting in a line, disinfecting the skin with the right antiseptics, and using the right kind of dressings. Other elements of insertion bundles include setting up of insertion line kits or carts with all supplies necessary, and having a team that is experienced and standardized at performing line insertions. So many hospitals have adopted these kinds of practices and often have an insertion line checklist that they run through to make sure that they're capturing all these elements. When it comes to catheter maintenance, again, hand hygiene is the one proven entity to reduce late onset sepsis. But there are several other items in the bundle, and these can be summarized as things that reduce bacterial entry into the environment. Of course, hand hygiene, reduce bacterial load in the environment, so doing all you can to keep the environment around the baby clean, changing linens, thinking of how to clean the baby's surfaces, and then thinking of how to reduce bacterial entry into the device. So diligent line care with dressing changes, standardized procedures for line changes and scrub hub policies that are standardized to make sure that we minimize the opportunity for bacteria to enter the line. These should form the core of any bundle. But of course, any bundle should be contextualized to the environment that you work in and what would make sense to your particular environment. So these are the core elements, but you could try to identify the set of them that really makes sense for your environment. Other common sense improvement strategies to reduce late onset sepsis. Breast milk use has been shown to reduce rates of late onset sepsis, so that's easy, low cost intervention that has to be emphasized. Development of standardized feeding protocols, which reduce variations in delays to getting to full feeds and decreasing number of days on TPN and number of days of central line exposure. Limiting use of drugs associated with late onset sepsis, such as histamine blockers. Also thinking about how to reduce the spread of resistant organisms within the unit by cohorting infants. And of course, antibiotic stewardship efforts go a long way to reduce resistance and subsequent risk of fungal infections. So using the narrowest spectrum for as short a period as possible. And through all of this, it's really important to monitor compliance and minimize practice variation. So I'm now going to switch gears and talk a little bit about the tools of how to make some of this quality improvement happen. The first step is really assembling your team. And no quality improvement work, especially not an infection, can work without a multidisciplinary team, which is comprised of not only neonatologists, but nursing specialists, infection prevention experts, experts in improvement science, and even people who help in keep the patient's environment clean. So all of these need to be part of your team. And don't forget the patient and their family. They are an integral part of any effort that you put out at infection prevention as well. And then we heard a lot about this morning. When you get started with a quality improvement project, try to develop a team charter and a very specific set of SMART aims. And try to clarify at the very outset who is responsible for what aspects of that charter. Here's an example of a key driver diagram at our Institute for CLABSI Prevention. It's really busy, but what I wanted to show you with this was the idea that, on the left in blue, we have our SMART aims, which are very specific about the rates we're targeting and when we want to get there with our rates of infections. And then we went ahead and thought about what are the primary drivers of this work? What are the big buckets in which we need to think about this work? And for us, one big bucket was thinking about our standardized bundle and how to develop our care based on that. The second aspect was how do we give our staff access to resources so that they can standardize and be highly reliable with the care they provide. And the third aspect is to think about how to promote organizational awareness about infections and infection prevention. So then, based on these primary drivers, we went on to develop our secondary drivers. We broke it down into a lot of detail, and this in turn helped to inform how we would develop our tests of change and go from there. So once we did key driver diagrams, the next step was to think about impact effort exercises. So you could come up with a laundry list of interventions, but it's really important to think about what is important to do in your context, what is likely to have the highest impact. So these impact effort exercises help get at that issue. On the y-axis, you plot impact, and on the x-axis, you plot effort for the interventions that you're proposing. And you really think about the interventions that line up on top, because they're the ones that are going to be high impact. And you really don't want to be thinking about the ones that plot out down below. But even among the high impact interventions, when you're starting a quality improvement in a project, it's really important to think about what is a quick, low effort, high impact intervention that you could start off with, because that'll give your team and your unit a quick win. It's what we call low hanging fruit, and that quick win can propel a sense of confidence in your unit and your team and move you on to take on bigger chunks of work. Another strategy that's helpful is process mapping. Again, this is an example from our institution where we worked on how to standardize our line changing process, and you can see it's incredibly detailed and you can't read the text. But the idea is to identify the vulnerabilities in the system where there's a lot of variation. They're circled in red. And doing this process of mapping out every single step of a process helped us identify where we could focus our efforts. So for your institution, for example, you might want to map out where your vulnerabilities in hand hygiene are and how you can tackle addressing those vulnerabilities. So this is a very useful exercise to employ as well. And then the next piece is really measuring your data. You have to audit to understand the current state of what's going on in your unit. And in our unit, we started using something called Kamishibai cards, where you audit based on your standard bundle. So there's a series of questions based on our standard bundle where we audit, but we also use the auditing opportunity to educate. And this auditing information is really helpful to provide us with the data we need. And then as we heard this morning, it's important not only to measure outcomes, but to also look at your process. So here's an example of what we do with our process. We look at the various elements of our prevention bundles. We plot out our compliance on a monthly basis so we understand how we're doing with compliance. And as you can see, over time, we've been showing an improvement in our compliance, and that's heartening to see. So it can give you a real understanding of where you're moving month to month and give you trends over time. This is a more complicated graph. In the lower half, we have our statistical control chart. We heard about statistical control charts this morning. This is our statistical control chart for CLABSI prevention in blue. And you can see our CLABSI rate varying up and down. And so in the left half of the graph, what you see is common cause variation. There wasn't any statistical significance. But as you move to the right half of the graph, we started seeing several points that were lying below the median. And this then began to contribute to special cause variation. Overlaying this graph, you see a bunch of vertical lines. We plotted out our PDSA cycles to try and understand which of our interventions were making the difference that was creating a special cause variation. And then finally on top, we actually mapped out our process measures in the purple line, which helps us compare whether our bundle is really working. Is it a change in our bundle compliance that's really impacting our outcome? So these are all tools. If you trend your data month to month and over time, you will eventually gain a true understanding of how your unit is performing over time, and will help you reflect on how far you've come from when you start a quality improvement project. It's also critically important to perform reviews of every infectious event to understand what could have been improved upon, what were modifiable factors and what were not modifiable factors. And it's crucial to have a multidisciplinary team talking at the bedside to try and understand where we could learn from the event and prevent it from happening again. Finally, no talk on quality improvement in infection would be complete without talking about communication and education. It is crucial to frame this issue the right way to staff. We have to get staff buy-in by telling them why it's important, teaching them the evidence behind preventative strategies, and empowering them to act on the evidence. It's also important to disseminate the data we have. Data should not remain limited to the core group of the quality improvement team. We need to disseminate our data to help drive our outcomes. And as we heard this morning, developing a sustained plan is key because early improvements can be deceptive, and if we don't stick with our improvement efforts, it's easy to lose the gains we've made. Finally, these efforts should happen in a non-punitive manner. It's important for us to celebrate success, which provides a cycle of positive reinforcement and helps staff do better as well. So this is a long journey to improving reliability, and it starts with process design, but it also goes on to ensuring that we develop a culture of high reliability in our organization, and we think about human behaviors and how we can make it easier for our staff to do the right thing. Finally, a quick word on collaborative networks. In the last decade, there's been a paradigm shift in the US in how we work on safety and quality measures, and there has been tremendous learning from working as collaborative networks. We share data, we benchmark, we learn from each other, and there's no institution too small to teach a big institution a good practice. And a key mantra has been, we don't compete on safety, all teach, all learn. So in conclusion, I hope I've convinced you that evidence-based quality improvement for infection is possible. I would like you to remember that improvement takes time, so be patient and be resilient. And improvement takes a team, so be inclusive. And of course, start with the basics. Hand hygiene matters for every patient, every time. Thanks for your attention.
That was an excellent talk.
Thank you.
Regarding, suppose you implement a bundle and you demonstrate benefits, is it at all necessary to find out which elements of the bundle actually worked? Because there could be some which are just piggybacking onto that bundle and not really contributing anything. And it could also happen that individually they're not, but only when they're done together, they actually work. So is it really necessary to do that, or you just simply continue with the bundle once you've demonstrated its efficacy?
That's a great question, and I think it's a dilemma that a lot of us struggle with. I think one key aspect is to start with the slimmest bundle you can so that you avoid some of those extraneous elements. And it is really hard to peel back once you implement something. In our institute, I can speak from our institution's experience, when we decided to pick a bundle, we actually began the difficult process of peeling back extraneous elements which did not belong to the bundle. And we called those PDSA cycles too. So we did some peel back interventions to peel back things that we felt did not belong to our bundle. And as we did each of these things, we watched our CLABSI rates and infection rates closely to see if there were any spikes. And thankfully, for the interventions we chose, there were not any spikes. So we felt justified in peeling that back. But it was really hard to get staff buy-in to peel back something that they felt was an established practice. So it is hard to do, and I think it's extremely hard to know which ones to pick as well.
Thank you, Lakshmi. So I think we are all quite highly sensitized by quality initiatives in infection control. Thank you for sensitizing us. Probably some of us will be very encouraged to start with the low-hanging fruits, as you said, start with small objectives and do a rapid QI initiative and then go on to higher things. Thank you, Lakshmi. Thank you so much.